you can hear me and can see my slides. It's a real pleasure to be invited to share some of the experiences that we have in Singapore and in the region about the use of precision methods in public health and in medicine. So I thought it would be useful to really start off by introducing what exactly is public health, because it's very common to think about public health as just simply trying to promote healthy living by looking at disease prevention, thinking about screening, and also managing complications and control and management of people with diseases. But actually, that's just the simple activities of public health. But we actually go much further when we start to think about effectiveness and also the cost effectiveness of strategies, like what Professor Furukawa has mentioned earlier on with his application, his online application approach. We need to evaluate whether it is effective, at the same time whether it is cost effective. So public health also looks after communications, education, advocacy, which I believe in COVID-19 has become very relevant to many countries and cities. And finally, it is around concepts of financing. How do we provide financing healthcare such that the country doesn't go bankrupt and it's sustainable and it reaches out to all people within the same country in a fair and equitable manner? That is actually the whole spectrum of public health. But what exactly is precision public health then? Because precision public health actually refers to all of the above that I talked about, but with the inclusion on the use of technology, on the use of large data sets to provide right kind of approach and evidence to the right people at the right time. And this allows us to target the necessary methods to measuring exposure, measuring the effectiveness of policies and programs. So that is what precision public health is. It's the concept of public health, but involving the use of data sets. Many of these data sets could be generated from genomics, it could be from spatial data, or even other forms of large-scale individual data. I will talk about some of them. But I think before we talk about individual precision data, I want to start off talking about the kind of data sets that one can get at a global level, because these are the kind of data that becomes very powerful in telling the world how have disease trends shifted in the past 5-10 years. This is exactly the kind of plot that we learned a lot about, because we see that other than COVID this year, the trend for communicable or infectious diseases actually have been reducing over the years. And it's been overtaken by non-communicable diseases such as cancer, such as diabetes. And exactly what are these non-communicable diseases? This is a plot that tells us very clearly what is the impact of respiratory conditions on chronic conditions, hypertension, diabetes, and cancers. And we could see that the trend clearly suggests that the world is facing an increasing burden of NCDs, and it's affecting people particularly who are experiencing longer life. So Taiwan, Singapore, Thailand, these are countries that have been very privileged to experience an aging population. People are living longer. But when people live longer, this is where the burden of NCD is rising disproportionately. And in fact, it is not a problem that is present in just high-income societies like Taiwan, like in Singapore. Even in middle-income, in low-income countries, we see a very rapid rise in NCD burden. But what does that mean? Because when we know that the burden is caused by NCDs, do we know what is driving the increase in NCD? What are the risk factors? And again, this is where data sets, large-scale data sets collected nationally with the right kind of measurements allows us to drill into really the risk factors that is resulting in a greater loss in life years. We see that smoking remains one of the highest risk factors, high body mass index, effectively high degrees of obesity. It's driving a lot of NCD burdens. Now the question is, if we know these facts, how can we now put in place the necessary approaches at the national, at the subnational level to start to address some of this issue? And that is what precision public health is about. The first approach is always to try and understand the problem. And that's where, with greater ability to measure accurately, including in Taiwan, you could see all the plots in blue highlights the non-communicable disease burden back in 2017 for Taiwan. And we could see what are the major drivers of losses in life years. Diabetes remains one of the highest, stroke remains one of the highest in a country like Taiwan. Now I talk about understanding where the disease burden is. So that is one use of precision methods, because once we are able to collect and collate data more nationally, you are able to understand the burden better. But equally, you are able to understand in Taiwan what is driving the greater increase in non-communicable diseases. Smoking, high fasting plasma glucose, high body mass index, high obesity, high blood pressure resulting from work stress, or high salt use, alcohol use. This effectively now tells us how do we target our policies in a better manner to target the risk factors better. So that is the first approach in precision public health, really understanding where the problem is, what is the magnitude of the problem, what are the drivers of the problem. Now, if we are able to do that, then we start to think about how do we change and improve the health system as a whole, nationally or subnationally, such that we put in place the appropriate policies and the appropriate programs to help people to finance the necessary healthcare and the health promotion architecture. So this is where I will now start to talk about something else, which is around monitoring and evaluation for effectiveness and cost effectiveness. Because at this stage, when we start to think about at the systems level, this is where we have to be always careful not to be distracted by new technologies, new innovations that come about. Because some of these innovations that come about could be very exciting, but it could be very expensive to deploy at a national level, or it could actually be not effective given the cultural context. And this is what I often talk about. Even for genetic testing to avoid severe drug reactions, there are genetic tests that are cost effective to deploy in Taiwan, but not in United States or in the UK. Equally, genetic tests to avoid side effects for abacavir and HIV drug is cost effective in a country like the UK, France, the United States, but actually will not be cost effective if we look at Taiwan, Singapore, Malaysia, China. So when we start to think about monitoring and evaluating, especially at the policy level, let's start off with these tobacco control measures. The World Health Organization advocated 5 to 6 measures that are determined as best buys for preventing and managing NCDs. And that includes taxation of tobacco products. It includes the use of cigarette bans or smoking bans in public spaces. But how do we know what is the likely effect on a society like Singapore? This is where, by adopting a modeling approach using mathematics, statistics, we are able to measure what is likely to be the impact if I now change the minimum legal age to smoke in Singapore from 18 to 21 or even to 25. If I now allow the use of e-cigarettes in the whole country, or if I just allow the use of e-cigarettes by prescription. Right now, Singapore, e-cigarettes and any associated products with e-cigarettes are all banned at the moment. But the question is, if we allow it, will it actually help the problem of tobacco, or will it actually make the problem even worse? And that's actually how we measure and we predict the impact of policies. Because otherwise, how would a government decide what is the appropriate policy to introduce if they don't have a way to forecast what is the likely impact on the outcomes that we want to look at. So when we come to cigarette use or tobacco control measures, we are trying to reduce smoking incidents in Singapore. We are trying to reduce the loss of life years because of smoking or the use of tobacco products. And that is where we can actually now measure and even try different combinations of policy approaches to see what is the likely long-term impact. Now, the vast majority of precision approaches has been very centered around individuals. And actually that is also the situation for public health. And this is where I'm going to show a few examples of innovations. Some of them are past innovations, some of them are very new innovations that are happening just as we speak at this point. That has to do with how do we prevent and perform health promotion, how do we screen people for diseases, and how do we try and manage complications when we treat people. And that is coming into the realm of precision prevention. Because right now we have heard from Professor Furukawa's talk that there are now ways that we can use analytics, online approaches to collect, analyze data sets about individuals, both at the cross-sectional level, but also at the longitudinal manner, knowing what is the trend that people eat, the trend of physical activity, the trend of medications, and so on. So our ability to measure the environment, our exposure to risk factors has gone up tremendously because of new technology. And we talk about genetics, so I thought it would be useful to pay respect to genetics because I started off as a genetics statistician. And in the prevention of breast cancer, that is one area that we have learned tremendously in the use of genetic data to perform risk estimation. And for breast cancer, there's a lot of evidence to suggest that the sensitivity and the specificity of genetic data is actually pretty high, such that we start to look at the positive predictive value, the negative predictive value, and it can actually make a population impact. So in Singapore right now, we have a uniform, a homogeneous breast cancer prevention program, where every woman above the age of 50 years old is subsidized for their mammographic screenings. But the question is, we know from genetics that the risk that women have for breast cancer actually differ. And in fact, at 50 years old, based on the risk profile of a woman, an average woman at 50 years old, we start to see that there are at least 40% of the women that will have the same risk profile when they are 46 years old. And if I now look at higher risk group, higher genetic risk group, there is actually 30% of women in Singapore society where at the age of 44, they will have the same risk as the median women in Singapore. And if we continue this, we will realize that actually, if I want to perform an equitable, not equal, but an equitable breast cancer screening program for women in Singapore, if I now have the ability to measure their genetics, I would realize that there are 5% of the women that I should actually start the mammogram screening more than 10 years in advance. So there are women that are at age of 30 plus that will have the same risk as what the country thought of at 50 years old. So that meant tremendous changes in the national policy for screening. So the question now comes, if I have to measure the genetics of all the women in Singapore, and now to perform early screening for some of these women, perhaps at the age of 35, some at the age of 40, some at the age of 45. Remember, all of this mammographic screening, I'm talking about subsidized mammographic screening by the government, together with the cost of genetic screening, genotyping. It turns out that after we perform this proper evaluation, taking into account of the accuracy of genetic information, the cost of genotyping, the cost of early mammographic screening, and also the savings that we get from avoiding or from early detecting someone who would have developed breast cancer, it actually is going to be cost effective. So right now, Singapore, we are in the process of looking at this from policy angle on how do we change the approach towards breast cancer screening and also towards population level genetics screening in Singapore. Because clearly once you genotype a person, the information will not just be used for breast cancer, it can be used for other forms of genetic related conditions, including avoiding side effects when they're taking drugs. So that's one example in terms of precision prevention or precision screening. The other approach that I wanted to talk about is really in the measurement of physical activity. And this area, many people know about, and in fact, I believe in the audience in Taiwan right now, many of you could be wearing an Apple Watch or Fitbit watch that allows you to track your physical activity. Now, we have improved tremendously from the past, where physical activity was measured using questionnaire, like the one on the left of the screen, that you remember how much physical activity that you have taken, and then you respond and say how much exercise do you do on average per week. Right now, we can actually measure this better, and in Singapore, because we understand that the cost of physical inactivity is actually very high. It's costing the country a lot, because in future there will be greater NCDs such as diabetes, obesity, and other forms that are related to obesity. Singapore actually has a national program called the National Steps Challenge. And the National Step Challenge actually provides free monitors that they give right now to about 1 million people in Singapore. You wear it like a watch, and then it counts the number of steps. And the number of steps, the information is uploaded whenever there is Wi-Fi connection. So there is a national platform to really understand, has people moved more after participating in these activities. We also perform similar research in the School of Public Health in Singapore, looking at how do we try and get people to be more active. Right now, all of you are sitting in the lecture theatre, seated down, so you will remain sedentary for perhaps 3 hours or more for today. But if you have signed on to one of our programs, you will actually have received a message on your phone or on your watch that says perhaps it's time for you to get up, stretch a bit, maybe go for a bathroom break. Just move about a bit so you don't remain sedentary for too long. The question is again, remember when I emphasize that with technology, with precision methods, whether it is in precision medicine or in precision public health, it is always a question of sustainability and effectiveness and cost effectiveness. So the circles here actually shows the amount of physical activity a person takes when they sign on to one of this digital monitoring program. And you could see that it's much higher than the baseline, which are the crosses. But when we stop the intervention, when we stop sending people reminders or we stop giving them incentives, you could see that actually people's behavior return back to the normal, which is pretty low. So this actually highlights the importance of sustaining such interventions. And this is why Singapore, we have partnered with Apple to launch a new initiative, which is what we call precision monitoring with the Lumi Health program. And it is going to monitor across a range of activity, not just physical activity, but also nutrition, also sleep pattern, also including health promotion, trying to remind people it is time to go for your vaccination, whether it is influenza, pertussis, measles, and so on. Or even for time to go for your screening, cancer screening, colorectal screening, breast cancer screening, HPV vaccination, and so on. So this is a partnership that has just been announced in September this year and has just been started rolling out actively in October, November, and December this year. In relation to that, there is also another approach that is again using mobile technology to try and measure and try and incentivize people to go for health promotion activity. And this is truly population health at its best for trying to drive health promotion. Because when we think about population health, the most important element is actually to try and remind people to go for their health screening, annual health screening, to go for their cancer screening, to go for functional screening for the elderly in terms of eyes, hearing, dental, public health, also in terms of trying to manage chronic diseases. So if we are able to have a platform that can very conveniently deliver reminders and also help people make bookings with GPs, with hospitals for their screening, for their vaccination, that will be a major advancement in really driving health promotion. Because the question of physical activity, fruits and vegetables, smoking have always been the same. Amongst all of us, including in the audience now, how many of you actually go for your health screening every year? How many of you actually have your fruits and vegetables, 2 portions of fruits, 2 portions of vegetables every day? And how many of you actually exercise 25 to 30 minutes on average every single day? All of us are working in health, medicine, but I think even we are not very diligent in keeping up with some of these known health promoting activities. So let alone the rest of the public that are not trained in health. So this is why digital technology is going to be quite an important game changer that is cost effective as well in trying to remind people to pursue or to take up health promoting activities. The question then is, when we talk about precision public health, what else needs to be achieved then? Because there are quite a number of technology developments, new apps that are coming online, new medical treatment, new genetic treatment, genetic surveillance technology, not just for NCDs, but also for infectious diseases as well. But the question has always been around the ability to roll this out at the national level and also to make this technology accessible and safe. So I will just use an example around for COVID-19. Right now, around the world, people start talking about delivering the COVID-19 vaccine. But how will this information be made available when I move about in public in Singapore? But if I want to travel over to Taiwan, how would me receiving the COVID-19 vaccine, this information will be made available to Taiwan operators at the airport, or even when I go shopping in Taiwan? Will that information be made accessible? Now, if this information is accessible, just like my physical activity, my nutrition level, my sleep patterns, if they are made accessible, how do I ensure safety and confidentiality? Some of these issues are operational but vital issues to be addressed in driving a precision approach, whether it is in public health or in medicine. One of the most important concepts that I keep highlighting is really around the issue of efficacy and cost effectiveness. Because while I talk about giving everyone a tracker to monitor their behavior, to monitor their physical activity, the Apple Watch on average costs between 300 Singapore dollars to 600 Singapore dollars, depending on which model you buy. Can we offer to give everyone an Apple Watch, even if we now show that the Apple Watch program with Lumi Health is extremely effective at getting people to go for their health screening, to go for their physical activity, to watch what they eat and so on? Because a technology may be effective at an individual level, but when we roll it out at a national level, at the population health level, it may turn out to be extremely cost ineffective because it will cost the government too much. And I think that when we start to go into this journey for precision medicine, precision public health, this lands on cost effectiveness at the national level or at the population level can never be forgotten, must never be forgotten. Because otherwise, it is so easy for people to start adopting very expensive technology where the benefits at the national level may be limited. I talk about data security, and in Singapore, that was one of our problems and one of our worries, because there were personal data that were accessed, and this data was subsequently shared on the internet, and it brought harm to some of the people. So data confidentiality will be a major challenge when we go into precision approaches. We talk about genetic tests, but how would this information be used in an appropriate manner without unduly penalizing people with perhaps genes that predisposes them to certain conditions? And will insurance companies, will workplaces, will my employer now be prejudiced against me because I'm at a higher risk for certain types of cancer? And if that's the case, how do we manage and to have Fair Employment Act in countries? So I would summarize my presentation with a few slides now. The first is there are three gains that we get from precision approaches. The first is that we are now much better. We have better ability to measure our environment, whether it is for health promotion, whether it is for disease prevention, and particularly for screening and surveillance of non-communicable diseases. So I think that's a clear gain, both at the individual level and at the national level, because we are starting to learn a lot about risk factors of the population. We are able to deliver very personalized messaging, because some people need strong incentive to get them to eat healthily, to stop smoking. Some people actually need messages that are work around the family. If I stop smoking, I may live to an older age to see my child get married, or perhaps to see my grandchildren get married. Those messaging needs to be personalized, because health promotion for too long has been very homogeneous, has been uniform, and we know that a standard message in health promotion doesn't work. The next is really how do we optimize our allocation of resources to the diseases, to manage the risk factors, or to specific groups of people that will genuinely change the burden of NCDs to a country. Because it is not just saying that I will vaccinate everyone against HPV. Are there certain risk groups that are at higher risk for certain forms of cancer because of HPV exposure? If that is the case, how do we ensure a greater uptake? How do we identify this group of people? And how do we identify the right kind of policies to target? I think that is the clear gains that we have from precision medicine and precision public health approaches, that we are moving away from that one-size-fits-all approach. But it is not, we are not there yet. There are a lot to do, and the three main things to do is, firstly, I talk about really understanding, is something effective? And when I think about effectiveness, this is where you have to start thinking about positive predictive value and negative predictive value. How many positive do I detect to generate one true positive? Just like a pregnancy test kit. If out of 50 positive results, only one is a true result, that is a very, very bad test kit. But that is what we think about when we start thinking about effectiveness. And this is exactly the reason why genetic testing for many other conditions, including diabetes, has not yet reached a level where we can start to use genetics to accurately predict the risk of a person and to provide specific intervention to help to manage that risk. Because the false prediction, the false positive prediction, is still too high for a health system to absorb. Because whenever I detect a positive prediction, it is not that simple to say that you are at a higher risk. I now need to manage your higher risk, perhaps by telling you need to exercise more, giving you more clinical monitoring and so on. All of that will cost money, and that's why we are always trying to measure the effectiveness and cost effectiveness. The next part is making sure that when we start to have all these digital techniques, this is accessible fairly and equitably by large groups of people in the population. Taiwan, Japan, Singapore, our societies are generally more homogeneous. There is less of a rural-urban divide or a very large rich-poor divide where they have problems for the poor to access healthcare. In our free countries, healthcare is much more homogeneous in its delivery. But in many other countries, when we start to think about precision approaches, there is a real risk that the expensive, effective techniques are only accessible by a small group of people. And finally, I think when we start to think about precision medicine, precision public health, actually a lot of the innovation comes from the industry, the private industry. That's where a lot of innovation, there's a lot of incentive to drive advances in understanding human behavior and understanding the effectiveness of drugs, technology, therapeutics. So I think the key to do is really how do we ensure that public health and clinical medicine remains sustainable, remains fair and efficient in its delivery to the population. And with that, thank you very much for the invitation to speak at this conference, and I look forward to interacting more with the moderator and with the audience.
Thank you so much.